Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon, respected teachers, seniors, and colleagues. I'm Dr. Madiha Sarwar, and I'm a hematologist at Chugtai Institute of Pathology. It's an absolute honor for me to be a moderator for this session. Hemoglobinopathies are the most prevalent genetic disorders with approximately 269 million carriers. Approximately 5% of the world's population carries gene for sickle cell disease and thalassemia, and the percentage of carriers can reach almost about 25% in some regions. Thalassemia is the most frequent hereditary disorder in Pakistan, with estimated prevalence of about 5 to 8%. The reliable detection and the identification methods for hemoglobinopathies continue to be a tedious task for the healthcare delivery systems, and indeed a very big challenge for them, as they are very important for the prevention of the disease. The chair for this hemoglobinopathy session would be Professor Dr. Samina Naeem. Madam is an eminent hematologist, a great teacher indeed. Madam had been a head of hematology department at King Edward Medical College and the Combined Military Hospital. Madam is currently working as the head of hematology services at Hamid Latif Hospital. The co-chair for this session would be Professor Dr. Iram Iqbal. Madam is an eminent hematologist. Currently, Madam is an associate professor at Lahore General Hospital. Ladies and gentlemen, now let's start our session of the hemoglobinopathies with our first speaker, that is Sir Dr. Asif Naveed. Sir is a consultant hematologist. He is the head of hematology department at University of Health Sciences. His topic of presentation would be hemoglobinopathies, diagnostic, preventive, and treatment milestones.
Thank you, Dr. Madiha. I'll be talking about hemoglobinopathies, diagnostic, preventive, and treatment milestones. I have nothing to disclose financially or otherwise associated with this topic or presentation. This will be outline of my today's talk. While history provides the canvas, it is vibrant brushstrokes of stories that paint the masterpiece of motivation, inspiring us to transcend our challenges and rewrite the narrative of our own journey. Starting from sickle cell, first description of sickle cell was made in 1910 by Dr. James Herrick. When he published literature on sickle cell, he was a cardiologist and he had a young patient named Walter Noel. He was a dentist himself. The patient was a dentist himself, and he was from the Caribbean island of Grenada with the disease under his care. Noel displayed symptoms of what we know referred to as acute chest syndrome, which is common complication of SCD. The blood film of the patient clearly showed the characteristic shape of sickle hemoglobin, which is the distinctive feature of homozygous sickle cell disease. This was well before the introduction of hemoglobin electrophoresis, which is the test that is currently used to diagnose SCD. So this was the first article by James B. Herrick in 1910, in which he described the peripheral film findings of sickle cell. And when we look back in the history about SCD, although Herrick described the first known case in the United States, SCD has existed for generations in families of African and Mediterranean descent. It was described in local African medical literature around the 1870s with the phrase Ogbenjis, which translate into children who come and go. Due to the high mortality rate of infants with this disease, one Ghanaian family traced the inherited disease back to 1670. And in 1922, a 21-year-old male patient was the fourth case of SCD in published literature and the first case that used the terminology of sickle cell anemia. This paper by Mason noted a common link between the first 4 recorded cases of the disease, which included the fact that all patients had African origin. This led to a common belief over the subsequent few years that the disease was limited to this population group. Since then, this association has not been found to be true. In fact, several other populations are affected by SCD, which include those from the Arabian Gulf, central India, the Mediterranean area of northern Greece and southern Italy, as well as eastern Turkey. And of course, Pakistan as well. Certain areas of Pakistan like Balochistan and KPK, and in southern Punjab as well. For the first time in 1949, electrophoresis showed that sickle hemoglobin moved at a different rate as compared to normal hemoglobin, suggesting a molecular change in the abnormal cell. When hemoglobin electrophoresis became widely available in 1954, opportunities to differentiate between different forms of SCD became possible. This led to subsequent subclassification of the disease as we refer to them today. And in 1967, HPLC was used to differentiate different proteins, and it was available in 1980s for hemoglobin diagnosis as well. So this was the Linus Pauling, who in 1949, who demonstrated sickle cell disease on electrophoresis as a different molecule. And in 1970, sickle cell anemia became the first human disease to be explained at the level of single nucleotide mutation. Using recombinant DNA techniques, scientists find that the nucleotide change in the DNA for sickle hemoglobin result from A to T substitution. 1983, the prophylactic penicillin study find that treatment of well sickle cell patients with penicillin could prevent death related to serious infections. In 1996, the multi-center study of hydroxyurea proves the usefulness of hydroxyurea in preventing complications in patients with sickle cell disease. And in 2001, gene therapy successfully cures a sickle cell mouse. This was about sickle cell, and then we know the Thomas Benton Cooley, who discovered thalassemia, who described thalassemia for the first time. In fact, that's why the anemia was called as Cooley's anemia. He reported first 5 cases in 1925 at American Pediatric Society annual meeting of American Pediatric Society. And then in 1927, he published the data of those 5 cases as well as 2 new cases. These are the first two cases reported by Cooley in 1927. You can see that, of course, there is an importance of observation. These 2 patients, they were sister and brother, 3.5 years and 11 months respectively. Comments by T.B. Cooley on the first 7 cases. These cases seem to belong to a fairly definite clinical group, though we must admit that our chain of evidence is not complete. We should define them as a form of hemolytic anemia, developing in early life and dependent probably on some congenital defect in the hemopoietic system. So if we see the milestones in thalassemia, Thomas Cooley first described thalassemia in 1925, which was described in a meeting of American Society of Pediatrics in 1925, and reported in literature in 1927. Thalassemia in 1938 was recognized as a genetic disease, and in 1948, thalassemia was determined to be caused by an abnormal hemoglobin. And in 1964, the thalassemia mutation was found to protect against malaria. In 1965, it was reported that treatment with regular blood transfusion begins to improve patient survival. And in 1977, prenatal diagnosis of thalassemia becomes available, which was based on paper of 1975, which was published in New England Journal of Medicine. And in 1977, Richard Proper discovers that iron toxicity caused by frequent blood transfusions can be eliminated by desferoxamine. This was the paper from 1975, which led to availability of prenatal diagnosis in 1977. This paper was published in New England Journal of Medicine, and then In 1962, azacitidine was found to increase fetal hemoglobin in thalassemia patients. Bone marrow transplantation was first time used to cure thalassemia in 1982 as well. In 1998, oral chelators such as deferiprone were shown to be clinically beneficial for the treatment of iron toxicity. And in 2001, specialized radiology imaging identifies iron toxicity in the heart. Hepcidin, a hormone that controls iron absorption in the intestine, was first discovered in 2001 as well. And in 2003, deferasirox, a new iron chelator, becomes available. And in 2007, gene therapy used for the first time. And in 2019, FDA approved LV-based gene therapy, lentivirus vector-based gene therapy. And in 2023, just 3 days back, Casgevy CRISPR-based gene therapy was approved by UK government for treatment of thalassemia. And of course, it can help in sickle cell as well, this CRISPR-based gene therapy. This was the literature, the case report regarding first bone marrow transplantation in 1982. It was published in Lancet at that time. Then there were certain drugs which were available, like which were under study during 2010 and 20s, but they never get fame because they never have curative intent. In fact, they have a management intent. Trablozyl is a recombinant fusion protein that binds several endogenous TGF beta superfamily ligands, thereby diminishing SMAD2/3 signaling. It promoted erythroid maturation through differentiation of late-stage erythroid precursors in mice in a model of beta thalassemia. This Trablozyl decreased abnormally elevated SMAD2/3 signaling and improved hematology parameters associated with ineffective erythropoiesis in mice. This was the paper published in 1998 for the first time, and then there were many studies which recognized that it can, be used in patients with ineffective erythropoiesis like beta thalassemia and MDS. And here is the Zynteglo, lentivector-based gene therapy. Bentaglogene autotemcel adds functional copies of a modified beta globin gene into patients' hematopoietic stem cells through transduction of autologous CD34 positive cells with BB305 lentivirus vector. After Zynteglo infusion, transduce CD34 positive hematopoietic stem cells engraft in bone marrow and differentiate to produce RBCs containing biologically active beta A T87Q globin, a modified beta globin protein that will combine with alpha globin to produce functional adult HB containing beta A T87Q globin. This beta A T87Q globin can be quantified relative to other globin species in peripheral blood using high performance liquid chromatography. And beta A T87Q globin expression is designed to correct the beta alpha globin imbalance in erythroid cells of patients with beta thalassemia and has the potential to increase functional adult HbA and total HB to normal levels and eliminate independence on regular RBC transfusions. In 2 phase 3 studies, betaglogene autotemcel was studied in 41 patients, and all studies of betaglogene autotemcel were open label, meaning that study participants and their doctors knew they were receiving betaglogene autotemcel. Each study ran for an initial 24-month period to assess transfusion independence. And 41 patients treated in phase 3 clinical trials in 2 studies, and 91% patient was transfusion independent after 2 years. And this is the story of Casgevy approved. Vertex and CRISPR, they are two CRISPR Therapeutics. They are two companies which designed this Casgevy gene therapy, and it was approved by United Kingdom MHRA for the treatment of sickle cell disease and transfusion-dependent beta thalassemia. 2 days back. So if we compare milestones in beta thalassemia and sickle cell disease, we can see that in 1950s, RBC transfusion was mainstay for both diseases. Then iron chelation came into existence and the patient were treated with that. And in 1980s, HSCT, hematopoietic stem cell therapy, was available, and first oral iron chelation was available in 1980s, and second was available in 2005. And hydroxyurea was available from 90s for patients of sickle cell disease, and in 2007 it was widely recognized. There were other molecules for sickle cell disease like L-glutamine, crizanlizumab, and voxelotor, and which can decrease the incidence of sickle cell crisis, and that's why they were highly appreciated in literature. Crizanlizumab binds to a molecule called P-selectin on the surface of platelets and endothelium in the blood vessel, and has been shown to inhibit interactions between endothelial cells, platelets, red blood cells, sickle red blood cells, and leukocytes. And in 2019, LV-based gene therapy, Zynteglo, as we already discussed, was available for beta thalassemia patients only. And voxelotor binds reversibly to hemoglobin, stabilizing the oxygenated hemoglobin state and preventing HbS polymerization by increasing hemoglobin's affinity for oxygen. So what is coming up next? Yeah, we have reached on LVV-based gene therapy for beta thalassemia, and CRISPR-based gene therapy for beta thalassemia and sickle cell disease. And we have coming up next is prime editing. The prime editing tool offers advantages over traditional gene editing technologies. CRISPR-Cas9 edits rely on non-homologous end joining or homology-directed repair to fix DNA breaks, while the prime editing system implies DNA mismatch repair. This is an important feature of this technology, given that DNA repair mechanisms such as NHEJ and HDR generate unwanted random insertions or deletions. These are byproducts that complicate the retrieval of cells carrying the correct edit. There are, 3 projects in Pakistan. Different institutions are working on these projects as well. One is based on CRISPR, and the other is based on prime editing. 2 institutions they are working on in mouse model. One is UHS and the other is as far as I know. So this is the article regarding prime editing in correction of beta thalassemia IVS 654 mutation in mouse model. So in conclusion, in the realm of medicine, the past holds the key to the future. The collective wisdom of history serves as a guiding light of research, offering invaluable insights that illuminate the path towards advancements and breakthroughs. Thank you very much.
I would there's no question. There are no questions regarding this presentation. Now I'd like to invite Dr. Rabia Ahmed. Madam is a consultant hematologist at Allama Iqbal Medical College. The topic of presentation is hemoglobinopathy, management in the reproductive setting and fetal diagnosis.
Bismillahirrahmanirrahim. My today's talk is about hemoglobinopathy, screening, counseling, management in reproductive setting and fetal diagnosis. First of all, dua. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. My Lord, expand for me my breast and ease for me my task, and untie the knot from my tongue, that they may understand my speech. Amen. As Dr. Asif has already discussed about thalassemia in detail and hemoglobinopathy, mainly sickle cell disease, these are actually heterogeneous genetic disorders, and they are typically inherited in autosomal recessive pattern mostly. Asymptomatic carriers to mild and severe disease, homozygous and compound heterozygous state. And hemoglobinopathies, they impact the quality of life. Some require lifelong care and can shorten the life expectancy in patients who are homozygous mainly. Significant advances have been made in the understanding of the molecular pathology, and we will discuss it later. Benefit of applying programs for carrier screening for an option for prenatal diagnosis recognized in many countries in which these disorders are prevalent. One of these is our own country. Infrastructure to support comprehensive screening and accurate diagnosis are not widely available in different countries, especially low-income countries where it is more prevalent and lack the resources. But fortunately, government of Pakistan is now very keen to support such programs. Were discussed here also. Prenatal diagnosis is offered to the couples with established pregnancies who have been identified as at risk for having an infected offspring. These are the actually target groups, and the information provided to the parents will allow them to make reproductive choices. It is up to them. Now, what are the tests for the screening such cases? These are divided mainly into two groups, first level test and second level test. फर्स्ट लेवल टेस्ट कौन से हैं? उसके अंदर हेमाटोकेमिकल डिफरेंट टेस्ट हैं विच आर फंडामेंटल टू आइडेंटिफाई दीज carriers as well as patients of hemoglobinopathy. And once identified, then they are encouraged that they will inform their other family members, and they will also ask them to undergo the screening in turn. और बहुत important, जिसमें सबसे important है, it is to identify the women who are affected by the hemoglobinopathies, and especially before they become pregnant or in the first few weeks, in the first week of the pregnancy. Few weeks of the pregnancy to identify and adequately monitor such health conditions. First line test includes complete blood count or full blood count as different institutes. It is routinely done, and then hemoglobin separation methods, and then RDR studies. These are actually the limits of the MCV, MCH, which is mostly used for the screening programs, in different screening programs. And then what are the methods which are used for separation? These are mainly HPLC, which must be a cation exchange apparatus with a double pump continuous linear gradient and CV less than 5%. Next is the important is the capillary electrophoresis, which is also reliable for screening and confirmation. And there is different techniques combination which is used, and both these techniques, HPLC and CE or capillary electrophoresis, are used in combination. And methods for evaluation of hemoglobin A1C are available, but they are not obviously, should not be used for diagnosis of hemoglobinopathy. And the only determination using HPLC and CE should be employed. Now, all of us know that hemoglobin A2, interpreting hemoglobin A2 is important for thalassemia trait, carriers of thalassemia, beta thalassemia, and should consider the factors which over or underestimate it. Same is the case for hemoglobin F. Values which are normal beyond the first year of life should be investigated with a second level test if associated with microcytic anemia and splenomegaly. If the patient has transfusion in the last 3 months, the first level test should not be used. Recently, iron deficiency, severe iron deficiency, mild iron deficiency usually does not affect the screening test. And in case of severe unresolved iron deficiency or beta thalassemia cases which are already ruled out by the first level test, they should be actually candidates for the second level. And at birth, like heterozygous beta thalassemia, hemoglobin Lapori or delta beta thalassemia, these cannot be identified accurately. A few words about the neonatal screening, and there are different methods like HPLC or capillary electrophoresis, both can be used. But neonatal screening programs can identify hemoglobin variants but may not be able to identify the healthy carriers of alpha and beta thalassemia. And at extreme prematurity, hemoglobin variants may not be identified. Data from reviews and economic analysis suggest that neonatal screening allows an early start of clinical checkups and antibiotic prophylaxis, which has proved to be crucial in reducing mortality from infections. Now, what about a few words about the second level test? These are the molecular analysis. Molecular analysis used in subjects with the non-conclusive first level test, and also in patients in which we have to confirm the diagnosis which is made in first level tests in few of the cases. And to correctly identify alpha plus thalassemia carriers, because there is no other option than the molecular analysis which is available. Carriers of very mild या silent mutations in beta globin gene key which can be missed in first level test. In those cases, there is availability of molecular analysis. And then suspected carriers of both alpha and beta thalassemia correctly define the thalassemia recurrence in the next generation. Now it is preferable to search for alpha and beta globin gene mutations if one partner is already found known to be a thalassemia carrier before the normalization of iron levels, even before it, because it cannot be delayed, prenatal diagnosis. DNA is taken from EDTA blood sample. It is the preferable, but other sources are also there. For example, it can be taken from saliva from the children in whom peripheral blood sampling is difficult, or it should be taken from buccal swabs from transplant recipients, because in those cases, जो definite diagnosis है, leukocytes of the donor in the saliva may be present, so buccal swabs are more preferable in those cases. Several DNA analysis techniques are used. We will discuss briefly about them. These techniques are, like in alpha thalassemia, techniques are reverse dot plot or gap PCR can be used as the first level screening for recurrent alpha globin gene mutations. In negative cases with strong clinical suspicion of alpha thalassemia carrier, it is recommended to proceed with a second level test, such as direct sequencing or MLPA, it can be used. Some laboratories which are equipped with NGS, it can be considered as an alternative to Sanger sequencing. And for subjects in which A2 borderline levels have to be confirmed, in that cases it is important to rule out with the molecular analysis, and in cases where the alpha gene, globin gene triplication or quadruplication is there, these are also important because in those cases it can be missed and patient may not get the accurate diagnosis of beta thalassemia. Now these are the different mutations, the mutational analysis which can be used. PCR, ARMS PCR can be used, Sanger sequencing, pyrosequencing, next generation sequencing. All these methods have their own advantages and disadvantages. Like ARMS PCR, it is easy to perform, rapid, possible use of commercial kits, but it is not, can recognize only known mutations. Sanger sequencing is also economic, but it requires specific expertise. Then is the pyrosequencing, it is rapid, easy to perform, but at the same time, it requires a dedicated personnel, and obviously, it is a difficult procedure for some of the institutes. And next generation sequencing, although it is very, can detect mutation in the whole gene, but it is actually high cost, has some reason that it is not practiced in most of the centers. Now HRMA is a rapid, sensitive, high throughput technique, but it requires specific expertise, and high cost is important. Then is the real-time PCR. It is rapid, high throughput, but it requires special expertise, and high cost is important. MLPA, it is also a simple, rapid test, can detect any copy number variant at the locus, but at the same time, it also requires specific expertise, and quality and consideration of DNA are critical in that case. Array CGH, can detect any copy number variant at the locus. Copy number variant means that the same nucleotide sequences can be present in the gene at different places. So those are the copy number variants. So all copy number variants, they can be detected by array CGH. Now come to the prenatal diagnosis. All the couples who are at risk of hemoglobinopathies should be offered a consultation. And these discussions should be non-directive, avoid jargons, and incorporate the cultural beliefs. And counseling should be offered prenatally and in the first weeks of pregnancy. External influences should not be there. And they should be allowed to make their own choice, informed choice, and preclude the possibility of access to some prenatal diagnosis technique. Prenatal diagnosis should be completed within 12 to 14 weeks of pregnancy. And then both partners should be simultaneously checked, preferably. And then prenatal diagnosis is not performed. If it is not performed, the choice is made that it is not performed, the infant should be checked within 3 to 6 months of life. And so that appropriate treatment can be initiated in those cases. P&D should follow dedicated procedures with coordination among the maternity lab, laboratory to optimize the sample report management. And then exclusion of maternal fetal contamination is mandatory because it can result in erroneous diagnosis. And then fetal karyotype analysis can be done if sample is adequate. PND report should be delivered as quickly as possible. One of the scenarios, the father refuses to undergo these carrier testing, or father to be is not available, like out of country hai ya is tarah ki koi problem hai, so it is important to perform PND to evaluate the risk of major hemoglobinopathies in the fetus. Then PND directly is required to be done. After specialist advice is given to the woman, who should be aware. So we come to the molecular techniques are the same as those used for postnatal diagnosis, which I have already discussed, and laboratory will adopt the most suitable technique, जो उधर available होगी और जो उस वक्त most suitable होगी, and it is considered useful to confirm the PND result after birth, using cord blood or by dedicated sampling in the first year of life, in case of an unaffected fetus. और अगर affected है fetus तो फिर patient should be the fetus the person should the newborn should be retested within the 3 months of life. ये different genotypes हैं जिसके अंदर recommendations हैं, तो जो बीटा नॉट और बीटा प्लस म्यूटेशन अगर दोनों स्वेयर हैं तो फिर तो 100% जो है वो बड़ी स्ट्रॉन्ग रिकमेंडेशन है पीएनडी की, और ये सारी जो हैं हेमोग्लोबिन लेपोरी के साथ बीटा नॉट या डेल्टा बीटा नॉट के साथ बीटा नॉट या बीटा प्लस है, ये सारी स्ट्रॉन्ग रिकमेंडेशन है. हाउएवर सम आर लो, like hemoglobin C, hemoglobin E, hemoglobin D, because hemoglobin D in homozygous state is not very much, is not symptomatic at all. तो उसमें फिर ये चीज़ें जो हैं वो इसकी low recommendations हैं. Then we come to the methods which are used. Cryonic villus sampling with CVS is the most commonly used method, and it allows one to obtain good quality fetal DNA between 10 to 12 weeks. Amniocentesis is another one. When CVS cannot be performed, technical issues हैं, for example posterior placenta, advanced pregnancy हो गई है, तो amniocentesis is performed after 16 weeks of gestation. 16 weeks of gestation के अंदर जो फिर amniocentesis के हमारे पास ऑप्शन है. फिर cordocentesis है जो कि लेकिन इसमें higher risk of miscarriage है. फिर cellucentesis है, it is the molecular testing after coelomic fluid aspiration can be performed from 8th week of gestation, or DNA extract from fetal erythroblasts are used, but it is done only in one center in the world. Now a few words about the hydros fetalis. In those cases, if they refuse to get PND done, then even ultrasonographic जो है इसकी diagnosis is possible by measuring the cardiothoracic ratio. I'll skip this because of time constraint की वजह से. Cells-free fetal DNA जो है, there is no evidence that this technique is so sensitive and specific. But studies are being done, or we will show the studies. Pre-implantation genetic testing, it is a very specialized topic. Therefore, couples deciding to undergo pre-implantation genetic testing are advised to contact an experienced assisted reproductive center, because udhar hi jo hai ye most appropriate place for the PGT. और जिनमें जो couples opt करते हैं PGT, they should not, they don't require to get PND or subsequent follow-up of the infant done. फिर gamete donation, although gamete donation is an option worldwide, but obviously it is not an option here. PND is performed, it is preferable to perform a carrier test in the child, ideally in the first year of life, and in the case of an affected fetus में 3 months में होगा, or informed consent should be there. In all cases of DNA analysis, pre and postnatal, written consent should be obtained, and from his or her guardian as well as current regulations, as per current regulations. And then medical reporting should be undertaken when the results of the tests are available. Few tests should not be used for a conclusive report. All reports should be written in a clear manner and with a short comment, and reports should include technical data and at the end a clear comment with any recommendations. Okay, now these are the non-invasive prenatal diagnosis of thalassemia through multiplex PCR, target capture and next generation sequencing, and it is done on free fetal DNA. Or just a few words taken from the study. The present study demonstrated the feasibility of non-invasive prenatal diagnosis through CFF DNA from the plasma of pregnant women through target capture and NGS. So furthermore, this test can be used to detect deletion mutation-based thalassemia at a relatively lower cost. फिर है prenatal diagnosis in Pakistan, beta thalassemia Pakistan, experience in a Muslim country. No study or no presentation about prenatal diagnosis is complete without mentioning General Sohaib Sahab. General Sohaib's contribution to this field is tremendous, और उन्होंने बहुत माशाल्लाह काम किया और कर रहे हैं, और उन्होंने फिर ये एक जो है इनके थोड़े से वर्ड्स हैं. Service for prenatal diagnosis of beta thalassemia was introduced in Pakistan in May 1994, and two renowned Islamic scholars were consulted before the service was introduced, and pregnancy is ruled out that a pregnancy can be terminated if the fetus is ruled that the pregnancy can be terminated if it is affected by a serious genetic disorder. Termination before 120 days is allowed. और फिर उसके बाद इसमें इन्होंने 300 कपल्स को में ये इनिशियल स्टडी थी, और उसमें इट वाज मेड बिटवीन 10 to 16 वीक्स एंड ओनली 15 वर रीच्ड आफ्टर द 16 वीक्स. डीएनए एनालिसिस आर्म्स पीसीआर से किया गया था. इस्लाम एंड टर्मिनेशन प्रेगनेंसी फॉर जेनेटिक कंडीशन इन पाकिस्तान, ये इम्प्लीकेशन फॉर पाकिस्तानी हेल्थ केयर प्रोवाइडर्स है. एंड ऑफ कोर्स मैडम शबनम, एक्स डायरेक्टर पंजाब थैलेसीमिया प्रिवेंटिव प्रोग्राम, और उन्होंने प्रिवेंशन और डायग्नोसिस ऑफ थैलेसीमिया इन पंजाब, उसके लिए मैडम ने बहुत काम किया और कर रही हैं. और ये मल्टी डिसिप्लिनरी टीम अप्रोच है, डायग्नोज ट्रीटमेंट फॉर मैनेजमेंट ऑफ सिकल सेल एंड थैलेसीमिया. और सिकल सेल में इम्पॉर्टेंट जो है वो है इसकी बिफोर ड्यूरिंग प्रीनेटली जो है या एंटीनेटली वीनस थ्रोम्बोएम्बोलिज्म के लिए जो है वो वुमन शुड बी गिवन लो मोलेक्युलर वेट हेपरिन. इट इज़ एन इम्पॉर्टेंट thing, and then infection control should be important, and if routine blood transfusions are there, then it should be continued. And there are now with advanced techniques many advanced quality and advanced treatment options. The thalassemia patients with thalassemia, females, they are now in the childbearing age, and there is also a need for them to be managed correctly. These are the references. And a few words about the Gaza doctors. We should not forget them. आजकल के क्राइसिस में जिस तरह वो काम कर रहे हैं, और जिस तरह वो बगैर पेन किलर्स के जो है लास्ट में पेन किलर्स के जिस तरह से वो अपने पेशेंट्स को ट्रीट करें, तो अल्लाह ताला उनको और हम सबको जो है ये हमें भी कोई इस तरह का हमारे पास भी हम भी उनके लिए कुछ कर सकें, लेकिन ये कि अल्लाह ताला उनको जो है इसमें और ज़्यादा जो है इस्तकामत भी बख्शे, और अल्लाह ताला मदद फरमाए फ़लस्तीन के मुसलमानों की. आमीन. Thank you for this.
We'll now proceed on with another presentation. I would like to invite Dr. Saima Farhan. Madam is a consultant hematologist at Children's Hospital, Lahore. The topic of presentation is role of automated analyzer in differentiating iron deficiency anemia from thalassemia trait. What we can offer new.
Bismillahirrahmanirrahim. First of all, I would like to congratulate organizers of PAP 2023. They have made an effort to bring all the 6 giant societies under one roof, और बड़ी amicably उन्होंने इनको manage किया है, और बहुत अच्छा इनका event हुआ है. Big hand of applause for all of them. The topic of my presentation today is role of automated analyzer in differentiating iron deficiency anemia from thalassemia trait. New Horizon. एक्चुअली ये टॉपिक जब मैंने चूज़ किया तो उस वक्त आई वाज स्टडिंग के सीबीसी के पैरामीटर्स हम लोग किस तरह से एक्सप्लॉइट कर सकते हैं काफ़ी सारी चीज़ों के लिए, और आई वाज एस्टोनिश्ड कि खाली सीबीसी के पैरामीटर से आप इतनी ज़्यादा स्क्रीनिंग कर सकते हैं कि यू डोंट नीड टू गो टू सोफिस्टिकेटेड टेस्टिंग. इसलिए कि सीबीसी इज़ द फर्स्ट पैरामीटर जो कि हर फिजिशियन हर क्लिनिशियन जो है एडवाइस करता है, और हीमेटोलॉजिस्ट और बेंच हीमेटोलॉजिस्ट अगर इन चीज़ों को ख्याल रखेंगे और इन चीज़ों का ध्यान रखें तो हम गाइड कर सकते हैं क्लिनिशियंस को राइट डायग्नोसिस राइट टाइम विद इन आवर फाइनेंशियल कंस्ट्रेंट्स. आई हैव नो डिस्क्लोजर. आई एम नॉट गोइंग टू गो इनटू डिटेल्स, इसलिए कि इंट्रोडक्शन ऑफ द टॉपिक हैव बीन वेरी amicably done by Dr. Asif and Dr. Rabia. As all you know, iron deficiency anemia is the most common cause of anemia, which is due to lack of iron, body iron, जिसकी वजह से HP कम होती है और patient present with anemia. And thalassemia trait, as you all know, is a genetic condition, but they have a overlap in clinical conditions. They can present almost the same sign symptoms एंड ऑलमोस्ट जो हमारे माइक्रोसिटिक हाइपोक्रोमिया के साथ ये प्रेजेंट करते हैं और बहुत डिफ़िकल्ट हो जाता है समटाइम्स हमें डिफ्रेंशिएट करना. एंड एज ए हेमेटोलॉजिस्ट यू नो कि अगर पेशेंट concomitant iron deficiency के साथ present करता है तो we are not able to diagnose these cases on even on HB electrophoresis until and unless iron is replenished. So they have overlapping blood count features such as low MCV, low MCH. So there is leading to consequence of misdiagnosis, which impact the patient care. Accurate differentiation ensure appropriate management such as iron replacement in iron deficiency and regular monitoring in thalassemia patients. And we can avoid ineffective therapies if we give the accurate diagnosis for the patients. It also has a role in preventive strategies as we can give genetic counseling to patients who are having thalassemia genes. And it also has public health impact. Thus, the accurate diagnosis aids in mapping disease prevalence and developing targeted public health interventions. जो traditional diagnostic method है, as you all know, is the CBC, and it indices. Then the next screening test is hemoglobin electrophoresis, serum ferritin, and iron test, iron profile जो है. लेकिन इसकी लिमिटेशन है कि ये कुछ इन्वेसिव है, टाइम कंज्यूमिंग है, कॉस्ट असेसिबिलिटी जो है वो बड़ी हमारे पास अंडर रिसोर्स कंट्री में डिफ़िकल्ट है हमारे लिए. और समटाइम्स नॉन स्पेसिफिक रिजल्ट, जिस तरह मैंने पहले कहा कि अगर ये पेशेंट्स आयरन डेफिशिएंट हैं तो हम डिफ्रेंशिएट नहीं कर सकते कि ये थैलेसीमिया माइनर है कि नहीं है. We have been seeing the advancement in automated blood cell count analyzers. I still remember that we worked with the hemocytometer. Most of my teachers, they must be knowing कि हमने manual hemoglobin measure किया हुआ है एक ट्यूब के अंदर, और उसके बाद फिर हम लोग उसी तरह MCV, MCA जिस तरह से measure करते थे manually, और वो सारा कुछ उसके बाद automated analyzers आए, और automated analyzers में से अब बहुत advanced चीज़ें आ गई हैं. So transition from manual blood cell counting to automated analyzer reduces the human error and it increases the throughput. Technical advancement like flow cytometry, digital imaging for detailed cell analyzing has paved a great way for diagnosing the diseases, and it also helps in real-time data processing, because faster processing of large volume of blood samples is easily with these automated analyzers. So they have an impact on hematological diagnosis with enhanced precision, and it also detects subtle abnormalities which are not able to normally can be overlooked by the consultant who is reporting these indices. आजकल आर्टिफिशियल इंटेलिजेंस का दौर है, एंड इट्स नॉट गोइंग टू बी कि पाकिस्तान भी इस चीज़ से अफेक्ट नहीं होगा. तो वी शुड बी वेरी मच अवेयर ऑफ दैट कि AI जो है वो पाकिस्तान में आ भी गया हुआ है, और वी शुड बी ओपन अबाउट दैट. मोस्टली हमारे जो इंस्टीट्यूट्स हैं, ख़ासतौर पर बड़े इंस्टीट्यूट्स हैं, वहाँ पे 6 पार्ट 7 पार्ट एनालाइजर्स प्लेस है, जिसमें सिस्मिक की सीरीज़ है, बैकमैन कूल्टर की है, एबट की है. तो जब हम उनके पैरामीटर्स देखते हैं तो फिर हम उसके काफ़ी सारी चीज़ें डायग्नोज कर सकते हैं. तो जो AI इन मेडिसिन, वी शुड बी ओपन अबाउट इट. AI refers to the simulation of human intelligence in machine programmed to mimic human thought process. A subset of AI involves the ability of machines to learn from and adapt to new data without being explicitly programmed. और hematology में it is helping or enhancing diagnostic accuracy, and it has many applications in blood cell analyzers, so they can provide more accurate differentiation like iron deficiency anemia and thalassemia trait. And artificial intelligence can streamline diagnostic processes, reduce turnaround time, and it improves patient outcome in hematology. Let's talk about the few emerging red cell parameters. As you all know कि traditionally हम लोग hemoglobin, MCV, MCH, MCHC, RDW इसके ऊपर rely करके तो हम सस्पिशन देते हैं कि दिस पेशेंट कैन बी आयरन डेफिशिएंट और थैलेसीमिया ट्रेट। इसके एडवांस कुछ पैरामीटर्स अब मार्केट में आ गए हुए हैं, कई एनालाइजर उसको ऑफर करते हैं, कईयों की हमें परमिशन लेनी पड़ेगी। तो उसमें से वन ऑफ द जो है न्यू पैरामीटर्स बियॉन्ड दिस ट्रेडिशनल इंडाइसेस आर सेल हीमोग्लोबिन कंसंट्रेशन मीन, hemoglobin distribution weight, and I'm going to discuss next few more. Significance of these advanced parameters is that they enhance diagnostic accuracies and they detect early signs of disorders. So as they have ability to recognize early stage abnormalities that traditional tests might miss. Few words about cell hemoglobin concentration mean, CHCM. It measures the average concentration of hemoglobin in a single red blood cell. इसकी clinical relevance ये है, it's particularly useful in identifying conditions that affect hemoglobin content of the cells, like in thalassemia trait and iron deficiency anemia. इसकी application ये है कि AI models can analyze CHCM variation to detect subtle differences between IDA and thalassemia, which might not be evident through traditional parameters like MCV, MCHC. Next is hemoglobin distribution weight, HDW. It quantifies the variation in hemoglobin concentration within red blood cells. Its insight into anemia is that it can provide the heterogeneity of hemoglobin concentration, which is a key factor in differentiating various types of anemias, so leading to enhanced diagnostic accuracy. AI algorithms can leverage HDW data to enhance the accuracy of anemia classifications, especially distinguishing between iron deficiency and thalassemia trait. The third parameter, new parameter that has been come in the market is red cell distribution with standard deviation, RDWSD. It is useful in identifying anisocytosis, which is commonly seen in various types of anemias, and it is when it is integrated as AI formulas. RDWSD can contribute to a more accurate diagnosis by highlighting the presence of abnormal cell variability. कुछ formulas भी इसमें अप्लाई किए जाते हैं, जिसमें है like percentage micro reticulocyte minus percentage hypohemoglobin and percentage micro reticulocyte minus percentage hypohemoglobin with RDW. इसकी एप्लीकेशन ये है कि डिफरेंशिएट आयरन डेफिशिएंसी फ्रॉम थैलेसीमिया. These formulas aid in distinguishing between these two conditions by analyzing patterns of the new red cell parameters. इसकी logarithmic efficacy ये है कि it reduces the likelihood of false positive or negative among the traditional methods. So when we compare the upgraded or new parameters with the traditional red cell indices, we can easily see there is an overlap between iron deficiency and thalassemia trait when we regarding the MCV, MCH, and RDW. So it leads to diagnostic uncertainty. When we do the comparative analysis with the improved model, there is improvement over traditional methods. AI-based parameters offer a more detailed and nuanced analysis. Reducing ambiguity, it enhances the ability to differentiate between iron deficiency and thalassemia trait. What is the impact of AI in hematological diagnosis? It refines the diagnosis. It customizes treatment plan as it gives the detailed data. When the detailed data is provided with these parameters, it can inform more customized and effective treatment plans for the patients. And obviously, future research, ongoing research in this area promises to uncover even more advanced parameters and AI applications, further revolutionizing the field of hematological diagnosis. ये कुछ formulas हैं या logarithms हैं कि जिनको एक्सप्लॉइट किया है कंप्यूटर ने और हमें जो हेल्प करते हैं, जिसकी बेसिस के ऊपर ये आर्टिफिशियल इंटेलिजेंस काम कर रहा है हेमेटोलॉजी के अंदर. These AI models are being increasingly used for complex diagnosis tasks in hematology. ये मॉडल फोकस होते हैं ऑन आर्टिफिशियल न्यूरल नेटवर्क्स, ANN, के नियरेस्ट नेबर, सपोर्ट वेक्टर मशीन्स एंड डिसीजन ट्रीज. Purpose of these AI models is that they are used to differentiate between conditions like iron deficiency and thalassemia with higher accuracy. AI has pattern recognition and prediction. These algorithms excel at recognizing complex patterns in data and predict diagnostic outcomes. These are the few articles which I studied, और तब मुझे एहसास हुआ कि we are doing nothing with the CBC. हम अभी तक पाकिस्तान में, और we can do a lot more. We can do more information to clinicians and help our patients for their diagnosis and management. The first article which I read was Automated Differential Count, Diagnosis Method of Iron Deficiency Anemia and Beta Thalassemia Trait based on nitrate CHI2 feature selector. This was published in 2021 in ISLH journal, in which Qatar author described the use of AI in their patient. The second article which I read was Diagnostic Performance of Hematological Discrimination Indices to discriminate between beta thalassemia trait and iron deficiency anemia, and using cluster analysis, introducing 2 new indices tested in Iranian population. This article was published in 2019, and they have developed 2 new parameters for diagnosing iron deficiency and thalassemia trait. This is another article which was recently published. It is the study from China, in which author described the new logarithmic-based discrimination formula for differentiating thalassemia trait from iron deficiency anemia, especially in pregnant females. And this is the most recent article. It is a review article which was published in May 2023. This article reviewed the application of artificial intelligence in thalassemia. A few words के ये सारी चीजें क्या हैं? Artificial neural network hematology में किस तरह से work करता है कि it mimics just like human neuron या human brain process. ANN simulates the way of human brain process information. ये जिस तरह ये एक एग्जांपल है कि इसने ये 4 पैरामीटर्स लिए और इनपुट लेयर और इसके बाद ये इसकी आउटपुट लेयर है. ये सिंगल लेयर मेथड है कि ANN ये डाटा उठा के मल्टीपल डाटास में से ये आइडेंटिफाई कर सकता है कि थैलेसीमिया और आयरन डेफिशिएंसी एनीमिया को किस तरह से हम बड़ी क्लियरली डिफरेंशिएट कर सकते हैं अगर हमारे पास CBC इस तरह के पेशेंट की आ जाती है. So when we process blood test data, especially useful in interpreting complex pattern in blood parameters, and the authors have come to understanding that ANN, artificial neural network, is more easily distinguish these kind of diseases like thalassemia and iron deficiency. So it has application in these diseases that it analyzes subtle variation. The AI is capable of detecting minute differences in blood cell characteristics that are indicative of either conditions. And in blood analyzer, there is integration of ANN in modern analyzer for sophisticated data analysis. Then the K nearest neighbor, it is also the same, uses a logarithm, and it helps in giving us the diagnosis of thalassemia minor and iron deficiency. The third is support vector mechanism. I just wanted to कि हम इसको थोड़ा सा डिटेल में डिस्कस कर लेते हैं, लेकिन सिंस टाइम की कंस्ट्रेंट है तो जस्ट एक खासतौर पे जूनियर्स के लिए है कि उनको ये पता हो कि ये लफ्ज़ क्या है और किस तरह से हम इसको एक्सप्लॉइट कर सकते हैं. ये लफ्ज़ सीख लें, समझ लें, बेशक जाके पढ़ लें, तो दैट इज़ ऑल्सो वेरी इंपॉर्टेंट. जिसमें डिसीजन ट्रीज हैं, SMVs हैं, ये किस तरह से हम यूटिलाइज कर सकते हैं हम अपने एनालाइजर्स में. तो इन्होंने ये जब स्टडी सारा किया है तो इनकी जो डायग्नोस्टिक एक्यूरेसी है AI मॉडल्स में, दे आर हाईली सेंसिटिव एंड स्पेसिफिक. और जो ANN है, showed excellent capabilities in pattern recognition, accurate classification. KNN or support vector mechanism have proved to be highly effective in classifying cases based on similarity and maximizing classification margins, leading to efficacy in diagnosis. And its implication for clinical practice is that they have potential widespread adoption it reduces the need for a confirmatory of test. They enhance speed and accuracy, and they streamline lab processes, minimizing human errors, and they avoid unnecessary treatment, leading to avoiding unnecessary treatments. When we collaborate, so we have to be open-minded to artificial intelligence, or when there is collaboration between clinician and AI, we have to itna open-minded hame hona chahiye ki AI tools are designed to complement, not to replace the expertise of the clinicians. They provide valuable data that can enhance clinician decision making. They equip the clinicians with more accurate and comprehensive data, supporting better informed clinical decisions and improve patient outcome. So there are new algorithms coming which lead to precision and efficacy. I've already discussed the ANN, KNN, and the real world impact is that AI-driven diagnostic facilities, early detection and appropriate management of these conditions improve patient care and treatment outcomes. Future directions are needed. There is continuous research and development of AI which promise further development in hematology, paving the way to more personalized and precise diagnosis. AI is not just a tool, but a paradigm shift in diagnosis and management of hematological disorders. Thank you. Definitely, I already told you that most of the centers, जो हमारे खासतौर पे बड़े centers हैं, वहाँ पे आपके पास 5-part, 7-part analyzers पड़े हुए हैं. जब आप उनका manual खोल के देखो तो it is described, these all parameters are described in these. लेकिन कंपनी वाले जो है उनको ये परमिशन लेनी पड़ती है अपने ना जो इनका प्राइमरी है, तो यू जस्ट स्टडी देम एंड आस्क द कंपनी पीपल कि हमें ये चाहिए. अभी रिसेंटली हम लोगों ने ना एक मशीन एक्वायर की है और मेरा एक रेजिडेंट उसके ऊपर काम भी कर रहा है, मोनोसाइट डिस्ट्रीब्यूशन विड. और सिंस आई एम वर्किंग एट चिल्ड्रन हॉस्पिटल, तो उसमें ना बच्चे बहुत ज़्यादा आते हैं जिनका इन्फेक्शन के साथ, तो CRP, ProBNP और पता नहीं क्या क्या टेस्ट, वो इतने हाई फाई और इतने एक्सपेंसिव टेस्ट कराते हैं. दैट इज़ गिविंग अस अ ह्यूज बर्डन, फाइनेंशियल बर्डन. तो अब ये जो हम इसके ऊपर स्टडी कर रहे हैं मोनोसाइट डिस्ट्रीब्यूशन विद अलॉन्ग के, ये फर्स्ट पैरामीटर जब CVC होगा तो उसी पे ही हमें पता चल जाएगा कि सेप्टिसीमिया है कि नहीं है बच्चे. तो हम ये क्लिनिशियन को एडवाइस कर सकते हैं कि डोंट गो फॉर CRP और एनीथिंग एल्स. आप सिर्फ CBC से ही बता सकते हैं कि इस पेशेंट को इन्फेक्शन है या इन्फ्लेमेशन के साथ है, और उसको मॉनिटर भी इसी के थ्रू करेंगे. जस्ट लाइक दैट आयरन डेफिशिएंसी और थैलेसीमिया ट्रेट में भी ना हम लोग डिफ्रेंशिएट कर सकते हैं. यू हैव टू गो टू देयर जो प्राइमरी जो है आपके कंपनी वाले, उनसे बात करके तो आपको मिल सकती हैं ये सारी. मैंने तो अभी तक जो देखा, मेरे पास 3 एनालाइजर, मैंने तीनों के ऊपर काम किया है, तो कोई कॉस्ट नहीं आती है. अगर ये कहते हैं कि कॉस्ट ज़्यादा आएगी तो नहीं होता, वही सेम रिएजेंट है, वही उनको सिर्फ परमिशन लेनी पड़ती है हमारे यहाँ के वेंडर्स जो हैं अपनी प्रिंसिपल कंपनी से, इसके अलावा कोई कॉस्ट नहीं आती है.
रक्सना, बस मुझे पूछना था कि ये रिप्लेस कर देगा हीमोग्लोबिन सेपरेशन मेथड्स को इन फ्यूचर आर्टिफिशियल इंटेलिजेंस?
एक्चुअली डॉक्टर आबिया, ये ना बहुत नंबर ऑफ सेट्स ऑफ डाटा देख रहा होता है, जिसमें मॉर्फोलॉजी भी है, जिसमें हीमोग्लोबिन की कंसंट्रेशन भी है. तो बड़ा हाई पोटेंशियल है कि ये जो हमारे स्क्रीनिंग टेस्ट है इसको रिप्लेस कर देगा, और वी कैन डायरेक्टली गो टू जिसमें हमें लगता है तो हम उसके ऊपर PCR बेस्ड जो टेस्ट है उसके ऊपर, इसलिए कि बड़े क्लियरली ये डिफ्रेंशिएट कर देता है. अगर पेशेंट आयरन डेफिशिएंट भी है तब भी हमें पता चल जाता है कि इसमें थैलेसीमिया माइनर की साथ है कि नहीं है.
थोड़ा सा इसमें कुछ मेरा अपना आई थिंक कॉन्सेप्ट, आई हैव टू क्लियर माई सेल्फ एज वेल. मेरा ये कॉन्सेप्ट है कि ये जो एडिशनल इंफॉर्मेशन है जो हमारे पास 5-part डिफरेंशियल के साथ एडिशनल जो रिसर्च पैरामीटर्स हैं जो कई मशीन्स में अवेलेबल है, कुछ उनको कह के करवाने पड़ते हैं. दिस इज़ अ पार्ट ऑफ मशीन लर्निंग और टेक्नोलॉजी एडवांसमेंट की फॉर्म है, एंड इट इज़ नॉट एक्चुअली AI. AI is when you फीड द डेटा और आपके पास मल्टीपल पैरामीटर्स हैं, लाइक अगर हम यूज़ करें थैलेसीमिया ट्रेट को डायग्नोज करने के लिए पेरिफेरल स्मेयर कर रहे हैं, इलेक्ट्रोफोरेसिस कर रहे हैं, RDW यूज़ कर रहे हैं, रेटिक यूज़ कर रहे हैं, उनमें से बहुत सारे ऐसे थैलेसीमिया ट्रेट होंगे जो उस डेफिनेशन, उस क्लासिफिकेशन, उन स्क्रीनिंग टूल्स के अंदर फिट नहीं हो रहे और आपको मोलिकुलर पे भी जाना पड़ रहा है. सो वो सारी इंफॉर्मेशन हैज़ टू बी गैदर्ड एंड ट्रांसफर्ड इन अ फॉर्म ऑफ अ डेटा. उसमें ये सारी चीज़ें जब इकट्ठी होंगी, ओवर थाउजेंड एंड मिलियंस ऑफ informations, then that would be significant. और उसके बाद हम ये चीज़ को कह सकते हैं कि हाँ जी ये थैलेसीमिया ट्रेट है, पक्का है, क्योंकि उसमें इतनी सारी हमारे पास इंफॉर्मेशन है और उसमें से फिर आपके पास शायद वो चीज़ हमारा टाइम जो आपकी होगी, आपकी एक्सपेंस होगा, जो वो चीज़ें कट डाउन हो पाएंगी. दिस इज व्हाट आई थिंक. आई डोंट नो इफ आई एम राइट और नॉट.
Yes, Aisha, actually पाकिस्तान में अभी we still have to work on that. But ये जो मैंने आपको स्टडीज पीछे बताई हैं, they have validated these tools. जिसके अंदर जो है ईरानी जो मैंने आपको स्टडी एक दिखाई है और एक जो कतर की दिखाई है, they have validated these tools और they are being utilized over there. तो वो डायरेक्टली फिर CBC से ना PCR के ऊपर जाते हैं अगर उनको लगता है कि ये थैलेसीमिया माइनर है, then they don't go for ferritin or they don't go for electrophoresis or what. They have already validated these tools. पाकिस्तान में still we have to validate them. Validate तो नहीं, मतलब हमें उनके प्रिंसिपल से लेके तो उसको अप्लाई करना है, इसलिए कि आई थिंक कि वही पैरामीटर्स वहाँ पे भी और हमारे यहाँ भी वही पैरामीटर्स हैं. यस यस, जिस तरह MDW जो है वो एडल्ट्स में जो है ये अप्रूव टूल है जिसके ऊपर ये यूटिलाइज कर रहे हैं. पीडियाट्रिक्स में भी है लेकिन स्टिल पाकिस्तान में हम लोग अभी तक इसको कुछ भी नहीं कर रहे हैं. तो हम लोग फर्दर इंफॉर्मेशन फ्रॉम CBC ही गाइड कर सकते हैं क्लिनिशियन को कि डोंट गो फॉर एक्सपेंसिव टेस्ट, और CBC से ही हम आगे सारी अपनी वो दे सकते हैं.
I just would like to add a comment. There was a time when I was a trainee and I had worked on differentiating between thrombocytopenia of aplastic anemia and ITP. And I had used at that time MPV, PDW and PLCR. And now we see CBC reports having PDW in them, isn't it? Yes. And immature platelet fraction. We are differentiating between hypoproductive and hypoproliferative and hyperproductive thrombocytopenia. They are helping us out so much. I mean, if we give the clinician IPF, they are able to differentiate what next they want to do without going to invasive procedures. So I agree with you, there will be a time we will be able to better use these parameters, and they are all available. In fact, one of my trainees is working on neonatal sepsis and some of the parameters given in our XN 1000. So there is a window there, and we can always investigate that what we can use. The thing is that you have to ask the vendor to make it. Sometimes they are not so. Sometimes you have to have the license as well. Sometimes they are available, and sometimes you have to get the license to use them. So there is a window there, and I agree with you that
I actually totally agree with Helen, and this is the right time. खासतौर पे जो young hematologists हैं, they should be knowing कि ये चीज़ें हैं और इसको apply करें. Thank you.
Thank you very much, Madam, for such a thoughtful and informative talk. It really broadened our horizons for the topic. Now we'll be having a session of presentation of the residential papers. For that, I would like to invite Dr. Mohammad Usman Siddiq. He is a resident hematologist at Chughtai Institute of Pathology. His topic of presentation is beta thalassemia mutation in subjects with borderline HbA2 levels.
Assalamu alaikum. My name is Dr. Mohammad Usman Siddiq, and I am a resident hematology at Chughtai Institute of Pathology. The topic that I am going to present today is beta thalassemia mutations in subjects with borderline HbA2 values. Before I start this presentation, I would like to state that this was a pilot study conducted at Chughtai Institute of Pathology in 2015 and consent has been taken from the authors to present this article at PAB 23. Starting with the introduction, thalassemia can be defined as inherited globin chain synthesis defects that form hemoglobin molecule. The pattern of inheritance in beta thalassemia is autosomal recessive, and it results from more than 300 point mutations. Clinically, beta thalassemias are mainly divided into beta thalassemia major, which is homozygous condition, and beta thalassemia minor, which is heterozygous condition. It is also referred to as beta thalassemia trait. More than 80 million people have the defective gene across the globe. According to the recent statistics, in Pakistan, beta thalassemia trait frequency ranges between 5 to 7%. That means there are more than 10 million carriers in the country, and every year around 5,000 children are diagnosed to carry beta thalassemia major. Hematological parameters including RBC indices followed by HbA2 estimation are the most commonly used screening tests conducted worldwide for beta thalassemia carrier identification and disease prevention. However, sole reliance on them can lead to misdiagnosis in individuals with HbA2 in the borderline zone, which may be atypical or silent beta thalassemia carriers. Mostly heterozygous beta thalassemia is clinically silent. However, accurate determination of the carrier phenotype is imperative for diagnosing couples who are at risk of having children with a genetic defect. The diagnostic characteristic of beta thalassemia trait is an elevated level of HbA2. There is inconsistency in defining the exact HbA2 cutoff above which an individual can be labeled as a carrier, and different laboratories use different ranging from 3.5 to 4% to define this lower limit. Many factors influence HbA2 level and thus affect carrier detection. Factors that lower HbA2 levels include concomitant iron deficiency, co-inherited mutations in alpha or delta globin gene, and silent mutations of beta thalassemia. On the other hand, megaloblastic anemia, zidovudine therapy, alpha globin gene triplication, and KLF mutations may spuriously raise HbA2 levels, resulting in a false positive result. The rationale behind this study was that borderline cases for HbA2 are often reported as normal, which are in fact disease carriers. These people have a risk of producing thalassemia major offsprings if married to thalassemia minor partners or people with silent mutations. Although beta thalassemia is prevalent in our country, but not many studies have been published till date to identify the mutations in borderline cases in Pakistan. The aim of this study was to detect various beta thalassemia mutations using polymerase chain reaction in subjects with borderline HbA2 levels so that such cases are not falsely labeled as normal. Material and methods. It was a feasibility cum pilot project conducted at Chugtai Lab in 2015. 25 samples were selected through non-probability consecutive sampling. Children with age more than 6 months, both males and females with HbA2 levels between 3 to 4% were included in this study. Patients having iron deficiency anemia or who had history of recent blood transfusion within 1 month were excluded from this study. Ferritin levels were done to rule out iron deficiency anemia. 3 ml blood sample was collected and run on Cebia for HbA2 estimation. DNA was extracted and ARMS PCR was used for mutational analysis. An approval was taken from the ethical committee of the lab and informed consents were taken from all the patients. Quantitative variables like age, hemoglobin, MCV, MCH, RBC count, and HbA2 levels were analyzed by mean and standard deviation. Qualitative variables like gender and patients having mutations were presented as frequency or percentages. Comparison of beta thalassemia minor cases with mutations and without mutations was done, and p-value of less than 0.05 was taken as significant. Moving on to the results. This is a tabulated form presenting the characteristics of patient. That is, total number of patients were 25, and in which there were 13 males and 12 females. Mean age was 23.88 plus minus 13.8. Mean HbA2 was 3.36 plus minus 0.27. Mean RBC was 5.06 plus minus 0.53. Mean hemoglobin was 12.43 plus minus 1.27. Hematocrit 38.6 plus minus 5.17. MCV 78.28 plus minus 7.17. And MCH 25.4 plus minus 1.6. 16 cases out of 25 showed mutation. IVS mutation was observed in 7 cases, out of which 1.1 was observed in 4 cases, while 1.5 in 3 cases. Codon mutations were observed in 4 cases, CAP occurred in 5 cases and all had +1. Most common mutation in our study was CAP1, no mutation found regarding frame shift and 619 base pair deletion. This is another table showing the distribution of mutations, and we can clearly see that CAP1, IVS 1.1 and 1.5 have the highest frequency, and these three comprise 48% of the total mutations in our study. This is a table showing a comparison of patients with an underlying beta thalassemia mutation and patients without an underlying beta thalassemia mutation. And we can clearly see there is significant difference in the HbA2 values, RBC count, and MCH as indicated by the p-value, which is less than 0.05 is taken to be significant. Moving on to the discussion, many factors influence HbA2 levels besides the beta thalassemia alleles, such as alpha thalassemia, delta thalassemia, and severe IDA. The co-inheritance of alpha or delta thalassemia and beta thalassemia carriers has also been reported to lower normalized HbA2 levels. It is hard to identify carriers as HbA2 levels does not fall in the typical range of carrier. These exceptional cases have borderline HbA2 values. This study identified cases where HbA2 levels, MCV, and MCH levels failed to predict heterozygosity for beta thalassemia and thus could lead to misdiagnosis of carriers. There is a difference in results as with similar study conducted by Rangan et al. In 2011, whose results were 32%, but the study was conducted in North India. Such variation in results may be due to geographical differences. In our study, most common mutation was CAP1. Results are similar with another study conducted at Kola et al. 2007 in Western India. Of the 25 cases, 16 cases, which is 64% of the total cases, showed beta thalassemia mutation. Heterozygosity for beta thalassemia was the most common cause of borderline HbA2 levels in our study population. These atypical carriers can be missed if molecular analysis of the beta globin gene is not undertaken in a laboratory setting and may potentially add to the beta thalassemic burden of the nation. As it was a pilot study in Pakistan, it might not be representative of the nationwide population, and not much literature was available at the time regarding borderline HbA2 cases. According to the mutation distribution, frame shift and 619 base pair deletion defects were not found in our study, and this may be due to small sample size. Moving on to the conclusion, heterozygosity for beta thalassemia remains the largest cause of the borderline HbA2 levels. However, the interaction of alpha, delta, or IDA in beta thalassemia heterozygotes as a cause of borderline HbA2 levels is not uncommon. Most of the borderline HbA2 cases, that is 64% in our study, reveal beta thalassemia mutations in them, which reveals the importance of PCR, as such cases can be easily neglected on HP electrophoresis or high-performance liquid chromatography. The misdiagnosis of such borderline cases can be responsible for transmission of the disease. This study strongly suggests that a comprehensive molecular workup of the beta globin gene should be performed when borderline HbA2 levels are encountered in the routine laboratory setting in cases where one partner is a carrier of hemoglobinopathy. Keeping in mind the financial constraints, there should be at least screening for CAP1, IVS 1.1, and IVS 1.5 in cases with borderline HbA2 levels, because these constitute majority of the mutations as found in our studied population. This will not only reduce the false negative results, but also reduce the burden of thalassemia in the future. These are the references used for this article. Thank you so much.
Thank you very much, Dr. Usman, for such an enlightening presentation. Now I would like to invite Dr. Saira Ahmed to present the topic of spectrum and hematological features of thalassemia and HV variants presenting at Punjab Thalassemia Control Program, Lahore region.
Assalamu alaikum, Bismillahirrahmanirrahim. I am Dr. Saira Gul, postgraduate resident at Allama Iqbal Medical College, Jinnah Hospital, Lahore. I am going to present the topic which is spectrum and hematological features of thalassemia and hemoglobin variants presenting at Punjab Thalassemia Control Program, Lahore region. Hemoglobinopathies are the most frequent genetically inherited disorders around the world with an autosomal recessive pattern of inheritance. Globally, around 240 million cases of beta thalassemia trait are diagnosed annually in Southeast Asian countries and Mediterranean region. Hemoglobinopathies are further categorized into two main groups, thalassemia syndrome and structural hemoglobin variants. In thalassemia syndromes, there is a defect in alpha or beta globin gene resulting in alpha or beta thalassemia. In structural hemoglobin variants, these are hemoglobin, sickle hemoglobin, hemoglobin C, hemoglobin D, and hemoglobin E. Of all the hemoglobin disorders, beta thalassemia is the most common single gene disorder in Pakistan with an estimated pool of 9.8 million carriers in local habitants. There is about 5 to 8% prevalence of beta thalassemia trait in Pakistan, which results in an estimated rate of 5,000 to 9,000 births with beta thalassemia major per year. The present study aimed to evaluate the spectrum of hemoglobinopathies along with hematological parameters. The data was contributed and provided by Professor Dr. Shabnam Bashir, the ex-director of Punjab Thalassemia Prevention Program. Now she is the director of Punjab Blood Transfusion Authority. A retrospective analysis of blood sample of 150 patients from 2015 to 2020 was done at Punjab Thalassemia Prevention Program, Lahore, for workup of anemia or other blood-related disorders. The blood samples were collected from the patients of low HP with suspicion of hemoglobinopathies who visited Punjab Thalassemia Control Program, or alternatively the samples were collected and sent by other pathology laboratories or clinics for the testing of parameters like CBC and peripheral smear. Patients with suspected iron deficiency anemia were excluded from this study. Hemoglobin analysis was done by high-performance liquid chromatography. Basically, it is a technique used to separate, identify, and quantify normal and variant hemoglobin. It consists of two phases. First is the mobile phase, and then is stationary phase. In mobile phase, this is a pump. It acts as a delivery system, delivery of solvent, and this is the injector. This side is used for the injection of sample, and this column is the hemoglobin from this side will go to the column, and it will bind with the negative charge column, and the different types of hemoglobin eluted, and it is detected by the detector and represented graphically as a peak in a separate window. This picture shows chromatogram. X-axis shows the retention time. Y-axis giving the detector response. Detector gives this response as a peak. Peak represents the concentration of the substance, but the peak may deviate, so the area under the curve or under the peak is considered as a measure of component concentrate. Hemoglobin A2 level, hemoglobin A2 value more than 3.5 was considered as a cutoff point for beta thalassemia minor. Analysis of data was done through SPSS version 20. Hemoglobinopathies were identified in 92.4, 137 patients out of 150 samples. Beta thalassemia trait was the most common hemoglobinopathy recognized with the prevalence of 17.2, with maximum number of cases in Lahore district of Punjab province. This table shows the frequency distribution. Thalassemia trait was the most common hemoglobinopathies detected in our study. It was 17.2%, thalassemia major 3.1%, thalassemia intermedia 1.3%, sickle cell trait 6.8%, sickle cell disease 2.7%, and hemoglobin D trait was 16%. HbH, HbLIV4 and alpha thalassemia carrier were the least prevalent hemoglobinopathies in our study. This is the bar chart showing the frequency distribution of various hemoglobin. When we see the association between the diagnosis and hematological parameters, we can see the patients with beta thalassemia trait presented with high RBC count, hemoglobin 8.2 plus minus 2.7, hematocrit 25, and MCV was 72.6, MCH 23.1, and MCHC 32, and RDW 21.5. With beta thalassemia, the RBC count was 2.5, HB 5.5, hematocrit was 17.3, MCV 71.2, MCH 21.1, and MCHC 32.6, and RDW 36.6. This is all about the other hemoglobinopathies. This table shows the clinical details of patients. Out of 150 patients, there was 45% female male patient and 55% female patient. 49 patients were Punjabi by ethnicity. History of transfusion was present in 19%, and the mean duration of transfusion was 3 months. History of hematinics was present in only 1 patient. Beta thalassemia trait was detected in 17.2%. The mean age at the time of presentation was 25.5%. Mean HB 10.8, hemoglobin F 1.2, which is normal, hemoglobin A2 5.07, and hemoglobin A was 92.18%. Beta thalassemia major was detected in 3.1%. Mean age at the time of presentation 6.8. Here's hemoglobin 6.1, hemoglobin F was 92.1, and hemoglobin A2 4.1, and A 3.7%. In sickle cell trait, mean age at the time of presentation was 19.5, hemoglobin 10.8, hemoglobin F was 3.06, A2 3.1, A 67.3, and hemoglobin S was 26.5. In sickle cell disease, with mean age was 11.25, hemoglobin 9.07, hemoglobin F was 22.4, A2 2.7, hemoglobin A 4.02, and hemoglobin S was 71.3. The patient with HBD trait was second most common, 16%. Mean age at the time of presentation is 23.3, hemoglobin 9.3, hemoglobin F was 1.05, hemoglobin A2 was 2.59, hemoglobin A was 68, and hemoglobin D was 29.3. The overall frequency of hemoglobinopathies in this study is 92.4, which is higher than a previous study done on patients at Islamabad by Waheed et al., revealing a frequency of 28.4. In other study conducted by Muhammad Salim et al. On distribution pattern of hemoglobinopathies in northern areas of Pakistan, out of 1187 cases of refractory anemia, 305 had thalassemia or abnormal hemoglobin. The study conducted by Shaista et al. Out of these 935 patients who had hemoglobinopathy, beta thalassemia minor 51.8, beta thalassemia major 24.1, hemoglobin D trait 6.7, sickle beta thalassemia 4.5, sickle cell disease 3.9, hemoglobin E trait 1.9, and sickle cell trait 1.7 were the most common hemoglobinopathies. Less prevalent for delta beta thalassemia, hemoglobin E homozygous form, hemoglobin D homozygous form, and HbH disease. The overall frequency of hemoglobinopathy in this study was 92.4. Reported study from Pakistan stated that beta thalassemia is the most common hemoglobinopathy in our region, particularly beta thalassemia trait. What are the limitations? High incidence of iron deficiency anemia in the population is a limiting factor which limits the reliability of HPLC results. This could be a reason for a reason of underdiagnosis. The limitation of our study is that it is not a general screening program. Rather, available data was retrospectively analyzed, so it may not reflect the actual number and distribution of hemoglobinopathies. Hemoglobinopathies are the most common inherited disorder in Pakistan and worldwide. Screening for hemoglobinopathy is recommended in infants after 6 months of age in high prevalence districts of Pakistan for thalassemia and other hemoglobinopathies. Sickle cell screening is also recommended in newborn in the high prevalence area of Pakistan, such as northwest region of Pakistan. Government and private sectors can play a significant role by targeting these high prevalence area in raising awareness about the importance of screening to reduce the disease burden. Our study will increase the awareness about prevalence of thalassemia and other hemoglobinopathies in Lahore region. It can also play a vital role in the formation of transfusion policies in blood banks. Adequate measures and screening procedures, especially prenatal diagnosis, should be performed concurrently with the aim to reduce the possibility of hemoglobin disorder in offspring, mental and physical trauma of affected patients, and socioeconomic burden of family. Screening is affordable and accessible way to detect carrier, and it can offered in the range of setting in different societies, in high schools, before marriage, and in antenatal clinics. These are all differences. Thank you so much for your time and attention.
आपकी mean hemoglobin 9 grams आएगी. So what do you think is the cause? Because hemoglobin D trait में usually HP तो लो बहुत ही कम लो होती है. क्या ख्याल है क्यों था?
मैडम जो मीन था वो तो पूरे डाटा का मीन था एचपी का. जो आप हीमोग्लोबिन डी की बात कर रही हैं जिसमें ट्रेट का
डी की बात कर रही हूं.
आप डी की बात कर रही हैं
आपने अलग-अलग किए हुए ना सबके पैरामीटर्स. तो हीमोग्लोबिन डी ट्रेट में आपने मीन हीमोग्लोबिन अपने जो पेशेंट्स हैं उनकी 9 शो की थी, 9 ग्राम्स
जी
पर डेसीलीटर. तो आपका क्या ख्याल है ये लो नहीं है? अगर सिर्फ आइसोलेटेड हीमोग्लोबिन डी ट्रेट है तो उसमें तो ज़्यादा होनी चाहिए,
नॉर्मल होनी चाहिए. मतलब नॉर्मल के अराउंड होनी चाहिए क्योंकि जब होमोजाइगस वो इतना वो नहीं होता तो ट्रेट भी नहीं होना चाहिए.
I was just wondering if there may be some additional reason for that low hemoglobin. जी मतलब
सस्पेक्टेड आयरन डेफिशिएंसी. हाँ जी, उसके साथ कॉन्कॉमिटेंट आयरन डेफिशिएंसी एनीमिया हो सकता है, उसकी वजह से उसकी एचपी.
और डॉक्टर उस्मान आपका जो पेपर था जो स्टडी है इसमें आपने क्या वो रेंज ली है जो बॉर्डर लाइन है A2 की? व्हाट वाज द बॉर्डर लाइन रेंज? जरा एक दफा दोबारा बता दें.
And the borderline was the HbA2 values that were between 3.3 to 3.9 that were taken in the study.
अच्छा 3.3 to 3.9. तो 3.5 से अगर ज़्यादा हो तो उसको तो वैसे भी हम ज़्यादा कर लेते हैं ना.
लेकिन उसमें थोड़ा सा आ जाता है कि बाज़ दफ़ा बॉर्डरलाइन ही देते हैं उनको हम लोग.
जी
ये वो पेशेंट्स हैं जिनमें यानी कि
आपका क्या ख्याल है? एक कट ऑफ अगर मैं कहूँ कि इसके अंडर सेफ आपको लगता है और इसके ऊपर आप डाउटफुल होंगे तो वो क्या कट ऑफ होगी? 3.5. तो फिर 3.5 से ऊपर जो पेशेंट्स थे वो तो आई नो इट वाज अ वेरी इंटरेस्टिंग स्टडी. तो 3.5 से ऊपर वालों को तो हम वैसे ही कर लेंगे ना स्टेड फॉर ट्रेट. और फिर उनकी हम कर लेंगे मतलब ट्रेट तो वो हो जाएंगे और उनकी फिर आगे अगर ज़रूरत हो तो जेनेटिक स्टडीज़ हो जाएंगी अगर ज़रूरत हो.
Sorry sir, I didn't get the question. So according to the, so we can label it as trait. We can label it as trait.
CBC parameters देखेंगे.
CBC फैमिली स्टडीज.
और जो है अभी डॉक्टर साइमा फरहान ने काफ़ी अच्छा अभी टॉक दी थी. आपके क्या ख्याल है इन पेशेंट्स में जिनमें आप डाउटफुल कौन से सिंपल रेड सेल पैरामीटर्स में कौन सा आप देखते हैं जो उसको
RBC काउंट?
यस ठीक. नहीं, RBC काउंट बहुत इम्पोर्टेंट है, ये इंक्रीज होता है, सही है।
जी
इनको ना इस रेंज को थोड़ा सा बड़ा इसीलिए लिया था कि बहुत सारी जगहों पे एक जैसे अगर आपके पास 3.5 आया है, कोई किसी जगह पे वही पेशेंट 3.6 रिपोर्ट हो रहा है, कोई 3.4 रिपोर्ट हो रहा होता, तो थोड़ा सा वाइडर रेंज हमने ले लिया था 3.3 से 3.9 जस्ट टू इंक्लूड। उसमें हो सकता है कुछ ऐसे पेशेंट्स आए थे जिनका जो वाकई ट्रेट थे, और हो सकता है कुछ ऐसे पेशेंट्स थे जो मिस हुए हैं, लेकिन इसको मज़ीद करना था क्योंकि मुझे सिर्फ मेरा टारगेट उस टाइम पे यही था कि ये बॉर्डर लाइन केसेस में मुश्किल होती है कि एक मोडालिटी हो भी नहीं सकती यूज़। जी,
इंटरनेशनल जर्नल ऑफ लैब हेमाटोलॉजी जो है उसमें ICSH की जो गाइडलाइंस हैं वो बॉर्डर लाइन कहती है A2 को, जो A2 2.5 से 3.5 हो, और उसके अंदर जैसे सर ने बताया कि आपको बहुत सारी चीज़ें थोड़ी सी देखनी पड़ेंगी। हिस्ट्री अगर स्ट्रॉन्ग है, फैमिली हिस्ट्री है, अगर माइक्रोसाइटोसिस है और आयरन सफिशिएंट है, RDW सजेस्टिव है, तो फिर you have to go further than just remain at this. Then you have to see अगर PCR है।
I think for youngster जो ना, जो especially जो newcomer the neonatal hematologist में, देखें, when you diagnose any disease, it's not one particular parameters. It's always combination of your history, physical examination, and your CBC and blood flow. I think the criteria जो भी बताया ना, the borderline is 2.5 to 3.5, not above than 3.5. 3.5 से above होगा तो वैसे में माइनर वैसे ही है, उसको तो आप सोचते नहीं है कि इसको मैं मोटेश जाऊँ। मेरी प्रैक्टिस क्या है, मैं अगर पेशेंट का हमेशा CBC देखता हूँ, ब्लड फिल्म देखता हूँ, स्पेशली फोकस ऑन योर MCV, MCS, रेस्टर डिस्ट्रीब्यूट एंड रेड सेल काउंट। रेड सेल काउंट इज अगेन अ वेरी इंपॉर्टेंट पैरामीटर। और स्टिल मेरा 3.5 या 3.4 आया है, आई गो फॉर दी फैमिली स्क्रीनिंग रादर देन गो फॉर म्यूटेशन एनालिसिस। म्यूटेशन एनालिसिस एक एक्सपेंसिव काम है, हर जगह होता भी नहीं है। पेरेंट्स साथ आए होते हैं, उसी वक्त हम CBC लें, CBC में पता चल जाता है कि थैलेसीमिया ट्रेट दोनों में है कि नहीं है। तो सिंपल तरीका यही है। दूसरा ये कि आप जो आपकी स्टडी है उसमें मुझे एक आया कि स्टडी वॉज कंडक्टेड इन 2015 एंड यू आर प्रेजेंटिंग 2023। इसका मतलब 10 साल के अंदर ये जो आप कह रहे हैं पायलट स्टडी है तो इतनी ज़्यादा हो चुकी हैं। हर वो केस जब बॉर्डर लाइन होता है वी गो फॉर द फैमिली स्क्रीनिंग एंड देन स्टिल इफ देयर डाउट देन फॉर द म्यूटेशन एनालिसिस, क्योंकि पेशेंट आपको अफोर्डिंग ही नहीं होती थी और हर जगह हो भी नहीं रहा। इसलिए ये हमेशा लेसन लेके जाएं, एक पैरामीटर से कभी डायग्नोसिस नहीं होती। हिस्ट्री, फिजिकल एग्जामिनेशन, ब्लड फिल्म, CBC ब्लड फिल्म, रेटिक और फिर फैमिली स्क्रीनिंग, दैट इज द अल्टीमेट गोल फॉर होम्योपैथी इन पाकिस्तान। थैंक यू।
Thank you very much, sir. Thank you very much, Dr. Usman and Dr. Saira, for the wonderful presentations. Now, to conclude our sessions, we were supposed to have a panel discussion, but Dr. Bushra is not here. So, we merged it with the conclusion session with Madam Dr. Samina and Madam Dr. Iram. So, to conclude our session, I would request the chair, Madam Professor Dr. Samina Naeem, a great mentor, and Madam Dr. Iram Iqbal, indeed a great mentor again, to enlighten us with their conclusive, precious remarks.
अच्छा जी, वैसे तो ये जो सेशन है ना, जनरल सुहेब के बगैर ज़रा अधूरा लगता है, क्योंकि उनकी प्रेजेंस नहीं अच्छा नहीं है, नहीं बहुत अच्छा होता अगर वो और भी ऐड करते। बहरहाल it was, I think, a very good session and a very interesting session. And the initial talk by the consultants, the initial 3 talks were very informative. Dr. Asif, actually it was nice to go through the history also. It's entertaining and enjoyable. And then it was the past, present and future. I must commend that the future, like gene intervention, genetic intervention for treatment, is probably quite a far goal for us, for our country. But still, we have to look into the future also. And then the antenatal diagnosis, it's very important. I think we should all strive, all the hematologists, they should strive to have more and more centers with the help of gynecologists. You know, it's a good thing to do chorionic villus sampling with at the gynae centers. It's not, I mean, it's not necessary that you should, the hematologist alone should do it. So in many places, you should take the help of the gynecologist, and I think that will actually promote this chorionic villus sampling. And the third talk by Dr. Saima Farhan, I found it very interesting. It is always very nice to think of new things, and you know, most of them were sounding new for the first time in our ears. And actually, interestingly, the platelet parameters, they have come into use with a bang and a boom. But although thalassemia is so prevalent in our country, somehow these parameters for thalassemia are still not being utilized fully. So I think this is really food for thought, and I'm glad that you have presented this, and I think it should be incorporated. And the two papers, they were very nice. Dr. Usman also presented it very nicely. The contents were very good. And I also agree with, you know, I face a big problem when I have something around 3.4, 3.2, 3.5. These patients really leave me disturbed mentally when I don't report trait in them. And the last talk from the Thalassemia Center, we had a lot of information in that. So we acquired a lot of information from that presentation, and it was a good presentation in that sense. However, you know, the frequency of hemoglobinopathy is as high as 94% roughly in patients of anemia. That, I think we have to, there's a reason for that. Probably the samples they got were for hemoglobinopathies, but if you consider all anemias in general, you will never get that percentage. So please don't go away with that thought in mind that in anemia that will be the frequency. But the data was interesting, and the information was very good. And I think the questions, the initial presentations, they didn't, I should say, incite, or there was no excitation for any questions. I was wondering why. In fact, the paper presentations, you know, ended up with more questions. So thank you very much for your patient listening, and I think we have, I'll invite now Dr. Saab, for your comments. And I think we've finished in good time.
थैंक यू सो मच. आई थिंक प्रेजेंटेशंस तो तीनों ही बहुत कमाल की थी, और हमने उससे बहुत नई चीज़ें सीखी. जो इम्पॉर्टेंट बात थी, जीन थेरेपी से लेके सीवीएस सैम्पलिंग और एआई, तीनों चीज़ें जो थी वो हमारे सब्जेक्ट्स जो कॉमन प्रैक्टिस में आता है उससे रिलेटेड है. और इंशाल्लाह विद पैसेज ऑफ टाइम एआई भी हमारी प्रैक्टिस में आ जाएगा. रिगार्डिंग जो पेपर्स हैं, पेपर्स में डाटा ज़रा इस तरह है कि कन्वे हो जाएगा कि शायद 92% पॉपुलेशन हीमोग्लोबिनोपैथी से सफ़र कर रही है. आई थिंक वो बहुत सिलेक्टेड डाटा होता है जो कि पंजाब थैलेसीमिया के पास आता है, वो पहले सीबीसी पे स्क्रीन हो जाता है. तो उसके लिए मेरा ख्याल है कि थोड़ा सा ये क्लियर कट मैसेज होना चाहिए कि इट्स नॉट मोर देन 7% स्क्रीन थैलेसीमिया ट्रेट रेट इन आवर पॉपुलेशन. थैंक यू सो मच.
Thank you very much, Madam, for your precious words. Thank you very much once again. Now we'll proceed with the shield distribution ceremony. To present the shields, I would like to invite Professor Dr. Shahida Mohsin. Madam is the ex-HOD of the Hematology at University of Health Sciences. She's a great teacher, a great mentor, and a prominent hematologist. Please, Madam, do the honors. The first sheet will be presented to the chair of this session, Professor Dr. Samina Naeem. Please, Madam. The next sheet would be presented to the co-chair, Madam Dr. Iram Iqbal. Dr. Asif Naveed, please do the honors of taking the shield. Madam Dr. Rabia Ahmed, please come on the stage to take the stage. Madam Dr. Saima Farhan, please come on the stage. The session. Dr. Usman Siddiq. Dr. Saira Ahmed. And the moderator. So with this, this is the conclusion of this session. Thank you all, everyone, the great mentors, the great teachers, and all the wonderful colleagues. It was an absolute pleasure to have you all here. So it's a time for a tea break, and that would be in the Grand Hall A and B. Thank you very much once again. Allah Hafiz.